Hello, welcome to Eye Contact, a video news programme on issues and controversies in ophthalmology, which is being produced by EUROTIMES. I'm Paul Rosen, and we're here at the 32nd Congress of the ESCRS in London. Now, ophthalmology, more than ever, is characterised by constant technical innovation. And one of the problems clinicians have in practice is how do you work out and how do you tell when it's time to introduce a new technology into your practice, and what's the best way of doing that? Today we're speaking with Professor Keith Willey of the London Business School, who's addressed this topic in a practice management symposium during the conference. So Keith, welcome. It's very great to see you. What questions should the clinician ask when considering introducing a new technology into their practice?
Right, well, I'd start by challenging a surgeon to think about the numbers. Think about their market, because I'm sure they will have investigated the technology and they will have dealt with questions of safety and efficacy. But I think they also ought to be asking themselves, who's going to benefit from this? Maybe it's only a few of their patients. I would challenge them to put some numbers on that and to run the numbers as to what it's going to cost them to run this treatment. And think also about whether this is going to allow you to make more money from your existing procedures, whether you're going to open up a new market and get extra patients, or whether this is a way of doing things quicker. All of those have different consequences in terms of what actions you're going to have to take. For example, you might have to work harder if you're able to do more routines.
And so really looking at the opportunity cost of providing that service and the benefit to the wider organisation.
Exactly.
Yeah. Are there some risks in being an early adopter? So how do you know when the time is right? Is that a clinical issue or is it a commercial issue, do you think?
Yeah, well, I mean, clearly, if you are an early adopter, you're basically saying that you're prepared to act on less evidence. Obviously, there are certain standards that have to be met to introduce anything into the market. But as an early adopter, you are working on less evidence. And I think acknowledging that actually you're going to tread warily, if you like, and regard it as an experiment, being very quick to adjust your approach on the basis of the evidence that you're getting back as you take on the technology.
But it can be a very expensive experiment. So if we take the example of femto lasers for cataract surgery, sometimes I think they're surgical tools and sometimes I think they're marketing tools. And I don't know how you sort of distinguish and whether you can put a value on its role as a marketing tool, for example.
Yes. I mean, there are examples, I won't name them, of where technologies come in and people have jumped on the bandwagon and subsequently discovered that perhaps the benefits weren't there and discovered too late. And of course then, actually, some of those people may have made money during that period. So the question is whether that's good enough test for yourself to have made money. Most surgeons would say not. So yeah, you've got to be wary of laying out a lot of money for something which isn't proven.
Okay. Next thing is, how much do you want to involve your staff in introducing a new technology? How important are they to that process and getting their buy-in?
Yes. I mean, I think that it might be a characteristic of surgeons to, if you like, appear from a back room where they've been studying some new technology and announce to the staff that they've got a fantastic new idea, or they've met somebody on a conference, and even after accepting that that's what's going to happen, at that point you need to involve all the staff, because we know that any kind of medicine functions as part of a more complex system, whether it's prep for the procedure or aftercare, or the way it might change your routines and processes and cause you to drop balls in other areas. So I would say it's absolutely crucial that the whole team gets involved.
So internal marketing is an essential part of that?
Internally. I mean, I would even extend it beyond your own staff. I think that part of the process of adoption of new technology involves market acceptance, which might be amongst your peers, could be amongst your GP referrers. So at some level, it's worth engaging with those people because they might point out things that you don't spot.
What about our patients who are, after all, our customers? Are there any sort of pearls for educating them and involving them in the process and informing them of the latest acquisitions of technology?
Yes, well, I think the first thing to say when educating patients about new technology is one has to be very careful about pushing technology and think about the ethics of that, and whether in fact you're inviting them to try improve and stuff and so forth. But assuming that you've taken care of that and you're very confident in pushing it to patients, if you like, introducing it to patients, I would say the first thing to remember is that not everybody can understand technology, that the people who are most likely to, where there's a choice, go for new technology are probably the more educated people who more likely can understand what the difference is. So I would focus on those people, and I'd say there's probably a happy coincidence that the educated people are probably the more wealthy people, which is a happy coincidence, because my other tip would be, if you're introducing a new technology, by and large, as a surgeon, I think you ought to avoid making it too cheap. That in fact keeping the price high, knowing that there are only a few people who are going to, if you like, convert early on, is probably a good thing to do. And then obviously after that, as you get more adoption, the prices can come down.
One of the criticisms of femtolaser has been, what's the clinical benefit?
Yeah.
But I think patients generally are quite switched on, and if there's no clinical benefit, then they won't buy it. Do you think that's a reasonable sort of way of filtering out technologies?
I think by and large that is something that we're going to go towards relying on more. I mean, there is clearly a consumerization amongst patients of healthcare. And people cite using the internet to educate themselves, but it's becoming more than that. I think a lot of health systems are relying on the patients being more informed going into that situation. Obviously that creates a bit of a hazard, because one might assume therefore that some of the risk and the burden is being put on the patient and taken off the professional, which would be a dangerous assumption, I would say. So yeah, I think in the end, the wisdom of the crowd, as people say these days, if that says the femtolaser's benefits aren't that fantastic, that will come out. But I think that professionals introducing it should ask themselves whether they're convinced, and all those kind of evidence is in place for them to try it.
And of course the benefits could be for the surgeon rather than the patient.
They might be for the surgeon, yeah. And I'm
making it a safer procedure.
Right, yeah. Which could itself be legitimate, as
yeah,
a reason for introducing it.
Yeah.
Yeah, absolutely.
Thank you. Keith, thank you very much for sparing the time. And for more information on this and the related topics, visit us at eurotimes.org. Thank you.